Okay, good afternoon everybody. I would like to thank Auntie Betty for her welcome to country and warm welcome. Thank you, Auntie Betty. I do also like to acknowledge the traditional owners of our land, the Wiradjuri people, and Auntie Betty and any other elders who may be present. And I would today also like to bring to your attention the health inequity that exists for our Aboriginal people, with 9 years less in their life expectancy than non-Aboriginal people. So a little bit about us. Murrumbdigee Local Health District, as Gail has said to you, is made up of a whole range of diverse rural communities. And our communities range from the vibrant city of Wagga Wagga where we stand today to a whole lot of rural and regional towns and our remote towns such as Hayhilston and Lake Cargelligo. We are home to nearly 300,000 people, and we also employ 3,000 staff, so we are one of the region's biggest employers. Aboriginal people, Auntie Betty, make up about 3.1% of our population. And over the next 17 years, we will see an increase in our ageing population. So currently we have about 18% of our population who are over 65 years. And in the next 75 years, we will actually have 28% of our people who are over 65 years. We need to think about that and what that means for our health service configuration, our mental health services. We have 29 local government areas, 31 facilities. We have many rural outposts, and Gail has mentioned some of them today. We also have 2 affiliated health organisations, the Mercy Healthcare Services. Here's a picture of our wonderful board who are sitting in the front row today so they don't get crimps in their necks like they did last year. They have actually done a wonderful thing for the staff of Murrumbdigee, and they have set us a very realistic, strategic set of directions. And I won't read them out to you because I'm going to go through each section now and just talk about a couple of the highlights that we have achieved over the last financial year. But I have to say that we've had the Rural Health Plan recently released, and I think that we've done very well, Murrumbdigee Board, because our strategic directions do configure and fit really nicely with the state's rural strategic directions as well. Okay, so the first one is providing healthcare in ways that meet the needs of our rural community. And when you have a look at the amount of work that we did in the last financial year, we actually treated 69,000 people in the hospital setting, which was an increased 9,000 people, staff, you looked after, 16% extra than the year before. But it's also very important to note that you also provided over 900,000 occasions of service to people outside of hospitals in the community setting. And the breakdown of that is 32% in dental, 5% in child dental, 20% in mental health, 4% in primary, and 54% in Aboriginal health. I do say, though, that we actually have a long way to go in how we do configure our services, and that's what we're working on this year. Also in the acute sector, we've provided good services in surgery and emergency departments. Certainly at Wagga Wagga Base Hospital, the team there have grappled with a very large number of emergency department presentations. So we have met our emergency department ED activity targets this year, so that means we're providing people within the triage categories, and also we've done more work, 1.1% more ED presentations, and we've treated more than 54,000 people in our emergency departments. So you'll see there the triage categories of how we actually filter out who needs the care quickest, and we have met all of those targets. We've also got a whole of hospital initiative because we can always do better. And I think all of you have experienced in your lifetime a wait in an emergency department. So Dennis has been acknowledged today, and I think his leadership in some of the changes at Wagga is really outstanding. And he's been the executive sponsor of a whole of hospital initiative, which is really focusing on the whole patient journey. It's not just about the emergency department. It's also about the whole of that patient's journey through the hospital and right through to their work going home. Griffith do outstandingly in this particular area. Their emergency access performance is absolutely outstanding, and I acknowledge their work there. Wagga's focusing on fast-tracking non-urgent patients and streamlining the admission of emergency admissions to the wards to free up room in the emergency department. In surgery, we've had a 4.6 increase in the number of patients that we have provided operations to. And I think you can see there 15,500 operations performed here. And importantly, we're a rural trauma centre, so we've also provided nearly 5,000, you can see there 4,500 emergency operations. And that's really important because in a rural area, there has to be a hospital that can treat trauma. So with surgery, you can see there at the 30th of June last year, there are only 2 patients who just popped over by a couple of days when we had a sick doctor on the waiting list. So really hats off to everybody. That was a team effort, Wagga, Griffith and all of the district hospitals. Also, we measured now on the time that people are admitted for surgery. So that's called the National Elective Surgery Time. And we met our targets there for urgent and semi-urgent, and we're just under target in our elective surgery. Workforce. Building a skilled and sustainable workforce. We provide 24/7 services in our hospitals. It's been a great year this year because we've had some wonderful improvements and initiatives in our workforce. And you can see there the breakdown of those nearly 3,000 people that I talked to you about, and the head count is actually 3,600. In terms of FTE equivalent, it's 2,849. And you can see that nurses are taking up 1,650 of those positions. So where have we done well? I'll start with medical. I think it was one of the issues that we've always talked about in our public meetings. In rural areas, the reliance of fly-in, fly-out locum doctors where we've got vacancies. And I think it's important to stress where we've got vacancies because we do have to provide our services differently in regional areas. If we've got permanent doctors, some of them do choose to live in other areas, and that's fine, so long as they're a permanent doctor. So this year, in our emergency departments, both at Griffith and Wagga, we've got new permanent doctors working, and that's been the first time in many years we've had some success in that area. At Wagga, you can see there that they've also recruited vascular surgeons, some emergency physicians, and some psychiatrists, and really importantly, some great success at Griffith with a new anaesthetist, paediatrician, emergency department doctors and physicians. So we've had a great year. We still have our challenges with locums. We have to focus on it every day and look to see how we can put forward initiatives to attract people to come and work in our region. Nursing is a wonderful success story, and again, acknowledge all the work done by Karen Carney. Where are you, Karen? She's up the back there. Look, again, if those of you who've been to public meetings in the past, we stood up here a couple of years ago to tell you that we had 200 long-term nursing vacancies in our region. It was a real challenge getting people with the skills to come and work in our small hospitals. It had to be able to do emergency, acute, aged care, paediatrics. Well, you know what? We've grown our own. So Karen and her team and some of her predecessors repeatedly over a number of years now have employed around 58 to 60 new graduate nurses out of university. And we've put nurse educators along by their side and we've taught them on the job. And it's been a very successful strategy, and it has really resulted in a committed workforce. When I look around the room, I see many, many people who have had a huge hand in this. Rosie Garthwaite, oh look, I could go around and mention many, many names, but it has been a team effort. And I think, guys, you can see there that the successes are wonderful. There's broader stability to our hospitals, which is really, really important. Allied health is also critical, and even more so now we're talking about integrated care. For us to be able to provide a full service in local communities, we don't just need doctors and nurses. We also need allied health. Those are people who take x-rays, provide dietetic services, physio, psychology, counselling. Really without those people, we're not a multidisciplinary full team. And again, we have really struggled in this area over the years. So Kathy Maloney's led a great strategy, all on her own actually, by really pulling together allied health professional advisor roles that will help really in retaining those people and attracting those people to come and work in our area by networking and being part of a team. So that's our workforce, a great start. But I think also we have to constantly think about how we're going to improve our models of care. We have to do that for 3 reasons. The first one is, of course, to improve outcomes for people. We constantly have to improve outcomes. We have to give people a better experience in the health service. But also, if we do those 2 things, we will also help manage our costs and our resources. So the focus is always on patient outcomes, always on patient experience, and lastly on cost. Sorry, Morris. So a good example of that, though, is this model of care that Jill Raymond, one of our directors, is working on at the moment, which is about how to manage people with fractured hips and fractured legs better. And again, this is something we're working on with the Agency of Clinical Innovation, and it is evidence-based model of care that produces better health outcomes for people, gets them home sooner. And of course, if you've got reduced lengths of stay, that helps you manage your costs. But for people, their experience, less pain, more timely care, earlier out of bed and walking around so they can get home and get back to normal duties and to normal daily living. And of course, preventing refracture in the future. This is a very innovative model, and Jill has actually led it with clinicians. It's about getting clinicians to sit around the table and agree to working in this way. So another one that we're working on is improving clinician community engagement. Gail mentioned our local advisory committees. So you notice that we've got, when we're talking about engagement, we always put communities and clinicians together because we can't do one without the other. And I am really proud because I do believe Murrumbdigee is #1, Gail, in this area. I think we've got more people there with 240 LHAG members across the region. We've also got thousands of volunteers and auxiliary members who help us deliver care to people. And I think being open and transparent with the public is also very, very important. And those people have raised almost $1 million in funds to help us make patient care more comfortable. Also, we are doing better in terms of some of our technology. And this is an area where we're really focusing in the years ahead. Some examples that Gail pointed out was point of care testing, and that's where we've got small devices, but they are linked up on the internet with the patient's medical record. So the prick of a finger, the results go into the medical record of the patient. And doctors can see it, nurses can see it, doesn't matter where they are. So some of the things that we can test for is haemoglobin levels. We can check if people are having a heart attack. And for people who are on blood thinning medications, they have to have regular INR tests. And some people are having to travel really long distances at high cost and inconvenience, and for them to be able to have those tests locally is really important. 28 hospitals have got those devices now, little devices that the nurses and doctors can use locally. Another one that we've been working on for a number of years is how we can actually take ECGs, which is heart tracings of people, and have them read by an expert, have them read by a cardiologist. And again, this is a very fancy piece of technology actually with, I think those ECG readings can go via America to get to the, in the cloud, to get to our doctors. And again, if you're in a remote community and we think you might be having a heart attack, that means that a specialist can look at your ECG and then prescribe treatment straight away, saving lives. Evidence-based practice, standardised care. So the other good thing that we're working towards is electronic medical records. And I have to say that these initiatives, I will proudly say, are self-funded by the Health District, probably by just the goodwill and sheer determination of Rosie Garthwaite, Andrew, Dag and Mark Massey, who are the managers of those sites. They went from having a completely manual system with pieces of paper everywhere to having an electronic medical record and a paperless environment. They did it themselves and they have not complained. They've been on a journey and they are waiting for the next stages to come down the line, and we're very, very proud of them. Why do we need EMR? We need it so that we can integrate with GPs. We need it so that we can integrate with the person-controlled health record. We need one health record so we can provide integrated care for people, and also helps to provide a much more effective service delivery for people working in the hospital. The next strategic direction is fostering effective partnerships. And I reiterate what Gail has said, and it has been a great joy to me since I started in August. I look forward with great joy to what we call site visits. And I think that's because I was a clinician myself, and every time I go back to a hospital, it all comes flooding back, particularly when we go to Tumut, because there's a picture of me there and looking very slim and beautiful, holding a baby, when I was once a midwife. But the site visits keep us honest. Truly see what is going on when you go and visit a community. We talk with patients, we talk with the staff, and we talk with the community, and that's how we really know what's going on. And Ken and I visited Hay, and Hay has come up in 2 stories today. We went actually in a little plane and buffered around the skies because we had a lot of people, and rather than 10 people travel in various cars, it was quicker for us to get in a little plane. But what we saw there was a very sick trauma patient. And I got back home here and I thought, I am really proud of the care that we provided that man. Everybody knows how we've struggled with providing medical cover for that hospital. There was a fantastic GP there who immediately linked in with the medical retrieval service. That man had brilliant nursing care, and even though the manager of the hospital was sitting in our meeting, she kept a very close eye on the oxygen saturation levels of that patient. She was running the show. And before we left, the retrieval plane was landing, and we actually were both in the sky. They were coming in, we were going out. And I thought to myself, for a little town, a long way from anywhere, for a man with a major trauma, we weren't there for long, we were only there for an hour and a half or something, Ken. That's pretty good care, and it's really heartening to see those stories. So, fostering effective partnerships, we must focus more in this area going forward, and I thank the board for giving us the challenge. I think health has worked too long in isolation. We cannot continue to work in silos. We have to get together with consumers, with our patients, their families, and all the other people in the community. We have to learn to let go. We are not the only experts in this area. It doesn't matter what piece of paper or qualification you hold, there are many people who can provide care to people in many different ways. And a good example of this is Finley, and I know Gail touched on it, but this is where you've got a problem and you've got a vision. And my team laugh at me. They keep telling me I say the word vision too much. But if you put people around a table and they share a vision, you can do anything. So these people in Finley, who'd never had a physiotherapy services in the lifetime that people could remember, sat down and said, we need it and we're going to get it. And they pooled their resources and they pooled their governance, and they came up with this fantastic model that Gail and I have seen. And this wonderful young man, who we got his photo, is a man from a private physiotherapy service called Back on Track Physiotherapy, and the Medicare local advisory committee, the hospital, and Murrumbdigee Local Health District have now, through integrated care and just a sheer will, providing services to people 3 days a week in a small community. Another really fantastic one that I'm proud of, Jan, and I have to say up front here that this was a piece of work that was not coordinated by Murrumbdigee Local Health District. It was actually coordinated by the Wagga Women's Health Centre. But it was an example again of people coming together with the vision and people having a conversation about what they want to achieve. And again, understanding that you can't work alone and that you have to get all the people around the table. So the integrated Wagga, it was initiated by the Wagga Wagga Women's Health Centre, but it's a regional plan, it's a strategic plan, and it will be implemented within an integrated framework. And I think this approach to women's health recognises each of the factors: biological, social, cultural, environmental and economic, that impact on women's health status. And the plan supports the need for women to be better able to access appropriate health services and really pays particular attention to the needs of rural women. And we thank all the partners, the Wagga Women's Health Centre, Murrumbdigee Women's Health Services, the Wagga Women's Health New South Wales, Wagga City Council and Family and Community Services. A fantastic piece of work undertaken by Gail Myers and the Wagga Women's Health Centre, who are an NGO. Okay, so we're coming down to the end now. Sarah's dinging away there, so I know I'm on the last few minutes. Last but not least, and you notice that we've got the bricks and mortar at the end of the discussion, because we've talked today about healthcare not just being about hospitals. We've talked about partners, we've talked about working in communities, we've talked about working with GPs in primary health, but we also do need to provide acute health services, and that's partially what we're funded for. And with 31 facilities, some of them are ageing, and we do have a challenge ahead of us. So I'll start with Hillston, which is a brand new NPS. We had a little old wooden hospital there that was very creaky on various levels. You almost got tilted sideways when you walked down the corridor. But there's a $12 million redevelopment going on there now, which will provide 24 emergency department access, residential aged care for 10 aged care residents, 5 acute beds for people in our community, and importantly, of course, those range of primary health services. Look, MPSs are a fantastic model for rural health services. It's a one-stop shop in communities for all the health services that they need, all under one roof. And the combination of state and Commonwealth funding provides a sustainable model for small towns. Also want to talk about Lockhart, and Lockhart redevelopment was a challenge. It was a very, very difficult build, but the result is absolutely outstanding. And as our Minister recently came and opened our new $8 million facility, she said it was a facility built with love. It was built in 3 stages, and the hospital had to operate in the hospital around the new build. So it was extremely challenging, and we thank our nurses and staff for doing that. Dennis, I'm sorry we put Wagga last. It is the biggest in terms of dollars, and it is the biggest in terms of projects. All of you who have been involved in the Wagga redevelopment project over many years, it's a $282 million rebuild, and of course the mental health service has already opened, which is stage 1, and in that financial year last year we had a wonderful celebration, opening 50 new beds for our district in a beautiful purpose-built building that I'm very proud of, Faye, and love to show you one day. And a brand new model of care, which I'm going to let Robin talk to you about, which is our subacute beds. So we're well on track now for the rebuild of our major hospital, and I think this time next year I'll be standing up here and telling you guys it's finished, and we'll be moving in soon, planning the opening. Okay, lastly, I just want to say that we've not only built buildings, and this morning I was adding up on my calculator how much we'd spent on equipment, and I was really amazed. 3.6 million. There's equipment everywhere that we've x-rays in, new x-ray machines in Holbrook, Tocumwal, Lockhart, Culcan, Henty, Tumut, Griffith, dental chairs in Wagga, operating tables in Wagga, new anaesthetic machines in most surgical sites. Griffith got a whole lot of patient monitors and new ultrasound in Wagga. So keeping up with technology is always a challenge, but we are investing in trying to provide state-of-the-art equipment for our people. Okay, now I'm going to show a video clip, but I think we might get Morris up in the first instance to present the financial results for the Murrumbdigee Local Health District the last financial year. And I'll come back on stage and play my little video clip after that. Thank you.